Hello and welcome to this very special feature. Do you know that cataract is the #1 cause of blindness across the world, including that in India, with millions of people getting affected by it? So what is cataract, or motia as a lot of people call it? Why is it so prevalent and what can be done about it? To know it all, we have with us in this very special feature today someone who's a veteran, a pioneer in this field. Please join me in welcoming on board to answer all the questions we have about cataract today, Chairman and Medical Director, Center for Sight Chain of Eye Hospitals, Padma Shri Professor Dr. Mahipal Sachdev. Thank you so much, sir, first for making time out of your schedule and being here with us. I would straight away dive into the first question that comes into mind, is that why is cataract such a big cause of blindness, not just in India, but all across the world?
So, thank you very much. In the first instance, I wish to say that what is cataract? Cataract means any clouding of the normal natural crystalline lens. Within the eye, there is a focusing lens which is called as a crystalline lens. With age, what happens is that this lens, which has proteins, these proteins start to become clumpy or they get denatured. Because they get clumpy or because they get denatured, therefore the lens which was originally transparent becomes cloudy. Okay? So this cloudiness of the lens is called as cataract. Now the leading cause of this cloudiness is age. With age, given a long enough age, like our hair go grey, similarly this lens is going to go grey or it is going to become opaque, and given a long enough life, all of us are going to develop cataract. So this is what is called as senile cataract. There are other causes of cataract. Even children can be born with cataract, which are called as developmental or congenital cataract. Diwali, Dussehra season, etc., cracker injuries, bow and arrow injuries, there can be injuries in factories, etc. So you can have traumatic cataract. That means because the lens has got injured, so therefore it becomes opaque. Then there are certain metabolic diseases, for example, diabetes, thyroid, etc., which can also increase the incidence or get the cataract, like COVID. A lot of people had steroids. So these steroid intake can also precipitate the onset of cataract. So the opacification of the lens is called as cataract. And why we are having so many cases of cataract is because longevity is increasing and the lenses are going grey or opaque, and therefore we are getting cataract. So that's a normal phenomenon. One important thing that you need to understand is that for reasons which are not fully known, Indians tend to develop cataract maybe 10 years earlier than their Westerners. It could be genetic, it could be a lot of sunshine, it could be malnutrition in childhood, etc. But there are several factors which one doesn't know, but we tend to develop cataract slightly earlier than what the Western population does.
Sure.
Now, the magnitude is pretty large. India does about 75 lakhs of cataract surgeries a year. And that is China, US and Europe put together. So that's the kind of numbers that we are doing, and we have only close to about 30,000 ophthalmologists in India, out of which you can say maybe about 18 to 20,000 are operating surgeons. So there's a lot of load that is there for each surgeon that is in India doing these cataract surgeries. Unfortunately, there are claims which are touted by people that by putting this or that drop, you can have the cataract go away.
Right.
As of today, there is no medical cure. Let me re-emphasize, despite these false claims, there are people who put homeopathic medicine, there are people who put Ayurvedic medicine, but there is no known medicine today which can retard or reverse the process of this clouding of the lens.
Right.
This is like you are changing age. Like there is nothing which is anti-aging, just now people age. Similarly, the lens of the eye has to age, and a person will develop cataract. So the only treatment that is there today is to do surgery. And therefore, in the absence of the facilities to do surgeries across India, maybe totally in the rural population, etc., this remains one of the leading cause of blindness. Fortunately or unfortunately, whatever way you want to put it, it is unfortunate that this is a reversible cause of blindness and we are not able to cater to all the blind people. But the fortunate part is that if you do get a cataract surgery, you will get your vision back.
How does one know that one's getting cataract? What are the symptoms of it?
So the main symptom of a person getting cataract is painless, progressive diminution of vision. That means it's not a sudden process, it's a slow onset, gradual diminution of vision. Then a person would maybe go to an optician and say, my glass power is changing. So there could be frequent changes of glasses. There could be a diurnal fluctuation that a person may see better during the day and see worse at night, or vice versa, depending on the type of cataract which is there. Then you could see multiple images from the same eye. So that is uniocular, that means from one eye. Uniocular diplopia means doubling, or polyopia. And sometimes you also see colored halos. So these are the symptoms. If the cataract goes bad, which is a rare situation, that means that jo safed motia, which is cataract, turns into a glaucoma, which is also known as kala motia.
Right.
Then the pressure of the eye goes up and the person can have sudden deterioration of vision. That is because of the lens getting swollen. But otherwise, painless progressive diminution of vision is the main symptom that a patient has.
How intensive, Dr. Sachdev, is a cataract surgery, the procedure itself?
Okay, so if we look at cataract surgery, there have been phenomenal advances in cataract surgery. Cataract surgery actually started out of India. That is India's, I would say, dein to the world, and that is Shushruta. Shushruta was the person who started cataract surgery by a simple procedure called as couching. So cataract, the center of the eye and the pupil through which the light is going, there is a cataractous lens there. So what he did was they put a needle there and he would dislocate or throw back the lens within the eye. So this pupil then became clear. Instead of like a curtain here, the curtain would be into one. That was what Shushruta did. And thereon the cataract surgery have evolved. Significant evolution, since maybe even when we were doing our post-graduation, that time there was an intracapsular cataract surgery where the entire lens was removed in one go, or it was in a single piece. And then the patient was given thick soda glass like lenses. Old movies you might have seen 10 power lenses that were worn outside in the glasses, which obviously didn't give good quality of work. So there have been bifold, I would say, improvement in the technique and technology of cataract surgery. The first thing is that the cataract is not removed en bloc as a single piece. Now the cataract is broken up into small little pieces with the power of laser or something called as phacoemulsification. We crush the cataract into small pieces and suck it out through a small incision. So the incision has shrunk from a larger incision, which was which was covering half the eye from 0 to 180 degree. It has now shrunk to only 2 or 2.2 millimeters. So this incision, because you have broken or pulverized the lens, you have emulsified the lens. The word that is used is phacoemulsification. Phaco means lens, emulsification means to break it into small pieces. So you are able to suck it out through a small incision. Now this small incision is self-sealing. It's like a pressure cooker. So if you can push out the thing, but when it closes, it seals. So the surgery has now become not that we are using any general anesthesia in these cases. Earlier the surgeries were done under general anesthesia. Even today, say in England, some places they are still doing under general, but we are now doing it under, then it went on to giving an injection around the eye to make the eye immobile. Now we are doing it just by drop anesthesia. That means you are just putting anesthetic drops onto the eye and the patient is supposed to look at the microscope. It has totally become a microscopic surgery. It has therefore, under topical anesthesia, we are doing the surgery. So this is no stitch, no injection, no patch, walk-in, walk-out kind of a surgery. So that's the kind of dimensions it has been changed, that you can today do a cataract surgery by taking drop anesthesia. It takes about 10 to 15 minutes and you crush the cataract into small pieces, suck it out, and from where you have sucked out the cataract, you are putting an artificial lens which is called as an intraocular lens, so the person doesn't have to wear thick glasses. So that is what the procedure is, and the highest pinnacle that is there after phacoemulsification or microincision cataract surgery is what is called as femto laser assisted cataract surgery. So with the help of a laser which is called as a femto laser, we are doing certain steps of the cataract, then which makes it more precise, more accurate, and the outcomes are much more better, and it is more gentle on the eye.
Thank you, Dr. Sachdev, for elaborating so well on how the surgery happens. And what about post-surgery? How is the visual rehabilitation post-surgery?
Earlier, when the cataract surgery was done and there was a larger incision, people were put in sandbags, like your head. There were no sutures at that time, etc. So there was an incision so that the internal parts of the eye don't come out. So the patient was supposed to be immobile and the heads were not moving. Therefore, typically these surgeries were not done in monsoons or in summers, etc., etc. But now, as I told you, that the incision has shrunk to about 2 millimeters or 2.2 millimeters. There is no stitch, etc. required. There is no irritation, etc. The eye looks pretty white. That means that there isn't any congestion, redness, etc. the next day. And typically, barring some unforeseen circumstances, the patient recovers a lot of vision within 24 hours or within few hours of the surgical procedure. There is no bed rest that is required, so you can go ahead and you can kind of resume your normal activities within a day or two, etc. But the post-operative, you have to put certain eye drops which are there from 4 to 6 weeks. Rehabilitated glasses, whatever little amount that is required, if at all, are normally given at 2 to 3 weeks post-operatively. But there is, it's reasonably, a lot of people have resumed their activities the next day or the day after. So that's the kind of speed at which the visual rehabilitation is happening, and no need for immobilization or putting the patient to bed is there.
Okay, and there's a lot of information around, if you go searching around on net about cataract. Is it true that you have to look at the weather before you perform the surgery?
So briefly, I had just alluded to you from the point of view of how the surgery was done earlier, etc. So therefore, because the patient had to be immobilized earlier, this I am talking about decades ago, and there weren't air conditioners and things like that, so it was normally preferred to be done in winters. The second thing was because the incision was larger, and even surgeries were done in railway stations, as I would tell you, cataract surgeries, or they were done in schools or temporary places which are not done anymore, etc. So the chances of infection were much higher when there was hot, humid environment. Sure. So therefore, what was a myth, which is now no longer the kind of patients. We still do more patients during the winters because old people still have those myths, but that is shrinking now. Weather has no effect whatsoever on the surgical outcomes, because there is no longer immobilization that is required, there is no longer sutures, there is no longer, and most of us have good weather conditions within the house, so there is absolutely no specific indication that you have to wait for this particular season to get the surgery done. It can be done at any time of the year.
And Dr. Sachdev, another fact check. Is it true that you have to perform the surgery only when the cataract has matured?
I think this again is a myth that needs to be rectified. We do not wait for the cataract to mature in today's circumstances to do the surgery. The surgery is indicated as and when an individual has difficulty in performing day-to-day activities. Nobody today wants to go bone blind and not be able to see anything and leave one's work, etc. to get the... So basically, if the cataract is totally mature, that means you're not seeing anything. Okay. So people are active now, even at 65, 70, 75, they want to do work. So if you are not able to read, write, watch television, drive, etc., whatever is coming in your way in your normal activities, you should go ahead and get your cataract surgery done.
Okay.
Now, why is this concept changed so suddenly? As I told you in the beginning of our discussion, was that when a cataract is matured, there are certain zonules which are 360 degree around the cataract which hold the lens in position. As the cataract keeps on maturing, that means it's aging, these zonules also become weak. Okay, so it is very easy to break these zonules. So we were taking out this lens or cataract as a single piece. So therefore, when the cataract matured, you were able to tumble out this entire lens and easily break the zonules without disturbing the back part of the eye, which is the vitreous.
Absolutely.
Okay, so that's what used to happen.
Right.
Now, when we moved on from the earlier surgery to phacoemulsification, where we are also implanting a lens. Earlier we were not implanting a lens, now we are implanting a lens. So if you conceptualize, say, a fruit, let's look at a coconut. So you slice off the top of the coconut, that's like making an opening in the anterior capsule of the lens. The lens is also enveloped by a capsule. So you are making an opening in the interior part of the capsule, going in with a phaco or with a laser, breaking the cataract into small pieces and sucking it out. Now this leaves behind an empty envelope, like you have the outer chilka of a coconut or whatever. So this is going to give you the support for the artificial lens. The artificial lens is now implanted into the same empty envelope that is there. So we want the envelope to be rigidly in place. That means that the zonules need to be strong, and we do not wish the capsule to move out after the lens has been implanted for times to come later on also. So therefore the situation today is totally reversed. We would like to operate the cataract at an immature stage and keep the capsule intact so that that becomes the support for the artificial lens. The second thing is that as the cataract keeps on maturing, the cataract tends to become harder. It becomes, the proteins become more compact. It could be as hard, say, like a beetle nut. So breaking that into small little pieces becomes more difficult. It needs more energy to break that, and that causes collateral damage to the other parts of the eye, that means the cornea, etc. So the recovery becomes slower. Right. So today's world, please get your cataract operated as and when you are having difficulty in your day-to-day activities. Do not wait for the cataract. Again, do not wait for the cataract to mature, because that will be counterproductive both for you in your life, as also your being ability to do things, as also for the surgeon to do a good surgical procedure.
Right. And since you touched upon technology so much, so one hears of this femto cataract surgery. Is that the most advanced technology that we have available? And where do you see technology in this field going ahead?
So, if you look at technology, the biggest thing in ophthalmology is that there are ways and means by which you can visualize any part of the eye. And because you can visualize any part of the eye, there are ways and means by which you can deliver. The light is a powerful source of light of the same frequency, which you are able to deliver on different parts of the eye. So what has happened now is that there is a laser which is called as femtosecond laser. Femto is a quantification of time. And femto, like you have these delivery which is called zepto, this is still faster, so this is called as femto. Femto is 1/400th of a second.
Okay.
10 to the power minus 15. So that is the brevity of the pulse. The femtosecond names comes from because this pulse, one pulse of this laser is fired for only 1/400th of a second. It is a very high intensity, high power pulse which is able to make openings in the lens, which is able to break the nucleus into small little pieces. It is able to make incisions in the cornea. So that is the femtosecond laser technology. It's called as FLACS, femto laser assisted cataract surgery, which is a semi-robotic kind of a surgery where you are first getting an in vivo, that means a real-time image of the cataract. You are getting a real-time image of the cataract, of the front part of the eye, and accordingly the machine is putting as to how, where, how much should be cut or how much should be the slicing and how much it is, and that is a semi-robotic surgery which has made it much more perfect, much more precise. Though there is a cost involved, so it has not become the standard of care, but anybody who can afford is going in for those procedures. Majority of my procedures, I would say 70 to 80% are with femto laser. Yes, it has equalized surgeons, I would say, because the skill set in doing this is slightly less than what you were doing earlier. But then there are 4 critical steps of the cataract surgery which are done by the femto laser.
So you elaborated very well on the surgical procedure, Dr. Mahipal, but what about post the surgery? How does the visual rehabilitation move?
Okay, so nowadays almost every cataract surgery, from where you are taking out the cataract, you are supplanting or implanting an artificial intraocular lens within the eye. Okay. Again, there is a story to this through the development of intraocular lens. After World War II, an intern was watching a cataract surgery being done by Sir Harold Ridley in England. And the cataract was taken out, and that's about it. The surgery ended there, and then the person was supposed to wear thick glasses afterwards. So the intern asked out of ignorance, he said, "Sir, aren't you not going to replace this by another by something to replace this?" So Sir Harold Reddy saw a World War veteran, an air pilot, who had a piece of shattered glass be lying in the eye. It was inert, it was not causing any reaction.
Okay.
And this question from the intern made him think about it, that because this is a piece of perspex of plastic, if we mold it like the glasses of the lenses, and we mold it and put it within the eye, and because it is inert, then you may obviate the need of putting thick glasses after cataract surgery, and therefore the term or the new technology that came in was called as intraocular lens. That means that within the eye you are implanting an artificial lens. Okay,
got it.
And this is something that is pure part and parcel. There has been several kind of improvements in this intraocular lens technology. Now we have foldable lenses. Like I told you that the incision has shrunk. Therefore, the artificial lens, which was made of plastic earlier, perspex, the same thing with which the glass windows of the aeroplanes are made, it is now made of acrylic material, or earlier of silicone, which could be folded on itself. And you can shove it through a small incision, 2 mm, and then when it goes, it opens to its full size. So therefore, we have foldable intraocular lenses which make the incision small. Now, in the optical principles, you have these lenses which we can measure by instruments as to what should be the power of the lens that needs to be implanted in the eye by certain preoperative parameters, so that the person needs very little glasses for use subsequently. So earlier the lenses were only monofocal lenses. That means that the lenses would correct the distance vision, but a person would still need glasses for reading.
Right.
Then came in binocular lenses or bifocal lenses, and now we have trifocal lenses because world has changed to smartphones. So you have actually three distances. One is distance, one is intermediate, computer, laptops, etc., or phones, and the third is reading. So now you have lenses which have optically been created on the same 6 mm platform, which is the lens that is being put into the eye, which give you three different focuses. So that is for distance, intermediate, and near. And therefore, with these lenses, you are reducing the dependence on glasses post-operatively. So we are able to get a patient significantly off glasses with this cataract surgery. And now also you know something like in the glasses you have a cylindrical power. So similarly, the lenses that are available today are called as toric intraocular lenses. So if the person needs a cylindrical power, you can even use these toric intraocular lenses, which can be either of the monofocal variety or the trifocal variety. So there has been these two parallel streams which have gone. One is the technology of cataract surgery, and the second is the visual rehabilitation technology in the field of intraocular lenses, that you are able to give the patient fantastic vision. It's like getting a patient, until of course there is some retinal pathology or some other pathology, he can see as good as when he was say 20 years old.
Thank you so much, Professor Dr. Mahipal Sachdev, for sharing such key insights on this very, very important topic of cataract with us. Thank you so much again for your time.
Thank you.
Moving ahead, what we understand is that with the right awareness and the right technology, we can tackle the very important challenge of cataract that lies ahead of not just of India, but all over the world. And we can enhance the vision of India, and we can do that without compromising on our life's experiences. Thank you again, and thanks for watching.